In this video, we will be discussing what will be the changes and MI features when there will be right coronary artery occlusion. Okay, let's get started. Before going forward, okay, let's jump into it. So, as we have already discussed, mnemonic for RCA, what was the mnemonic? It was RIP, R-I-P, RIP. R for right wall, right ventricular wall, I for inferior wall, P for posterior wall. Okay. First of all, let's discuss about the inferior wall. Okay. So in case of inferior wall, if there is inferior MI, what are the leads to be looked for? So you will be finding changes in case of inferior leads, and what are the inferior leads? Lead 2, lead AVF, and lead 3. So what will be the changes you will be finding? So let's say this is lead 2, this is lead 3, and this is AVF. So you will be finding ST segment elevation of a T wave. Let's draw like this. So when you draw an isoelectric line, so this is your isoelectric line, there you see there is ST segment elevation and upright T wave. And we have also discussed the reciprocal relationship. The reciprocal relationship, what is reciprocal relationship? If there is inferior wall MI, then ST segment depression and inverted T wave will be seen in anterior leads. So look for anterior leads. There might be ST segment depression and inverted T waves. And what are the anterior leads to be looked for? V3 and V4. Okay. Okay, good. One thing you need to keep in mind is that most of the cases inferior wall MI is caused by occlusion of right coronary artery, and that also being the distal most part if it is isolated inferior wall. However, during this course time, you also need to think is that posterior wall will also be involved eventually. Suppose if the occlusion is only this much part, then possibly inferior wall could be only isolated. However, if occlusion is here, then posterior wall will also be involved. So that ideology you should have. So what will be the changes in posterior wall MI, we will talk later on. What I wanted to focus in this video is that 80% of the cases inferior wall MI is caused due to right coronary artery occlusion. There are 15% of the cases when people they are like left coronary dominant or co-dominant cases in 5%. In that cases, inferior MI could be because of left coronary artery occlusion. So you need to be spectacle and look for features of left coronary artery occlusion. So if left coronary artery is occluded, then you can find different lesions that we have already discussed in case of left coronary artery occlusion in previous video. Like LAD may be involved, lateral wall may be involved, so septum may be involved. So those leads also you need to keep in mind. Okay. Now we will be discussing what will be the changes when there will be posterior wall MI. There is distinct pattern which you will be finding in posterior wall MI is that because one thing you need to be clear is that suppose this is your heart, as we have already taken example, this is your heart and you have your chest lead in front, but now the lesion is behind, that is posterior wall, infraction is this part posterior, isn't it, posterior here, but you are putting the chest lead here, so the ST segment elevation and depression won't be seen in anterior leads. Reciprocal relation will be seen in anterior leads, that is lead V3 and V4, they will have ST segment depression and inverted T wave in case of posterior MI. So I will make it clear. So in posterior MI, or suppose if there is some defect you find in lead V3 and V4, in lead V3 and V4, if there is ST segment elevation and upright T wave, then it can be anterior wall MI. However, if V3 and V4 is involved, but there is depression. There is depression of ST segment and T wave is inverted. Then you must suspect for posterior wall MI. So what will be the ECG finding? So this is P wave, and here it will be like this. It will go there, and it will go like this. Here it will be, this is inverted. So you see here. So this is PR segment, this is your isoelectric line, and you see here, this is the depression of T wave ST segment, and you see the T wave is inverted here. So there will be depression of ST segment and T wave inverted in V3 and V4, then suspect posterior wall MI. However, posterior wall MI are generally picked up late, so it will take days to see such changes in V3 and V4. But genuinely speaking, you need to look from V7 to V9, which are located in posterior part. Suppose posterior part, that means in back, and in that case you will be finding positive ST elevation. But when you look for V3 and V4, because they are placed anteriorly and lesion is posteriorly, so there will be the reciprocal finding will be seen. So is it clear? Okay. Now we need to discuss what are the changes, or what are the changes seen in different leads when there is right ventricle, right side of the wall, heart wall is involved. So lesion is in right wall, okay, and generally speaking there are no such particular leads looking at the right wall, but V1 is the major specific one which you need to look at. So when there is ST segment elevation and V2 it has ST segment depression, then suspect for right wall lesion, or you can say V1 is isoelectric, and V2 is ST segment depressed or ST segment elevated, and the ST segment elevation in V1 is greater than V2, then always suspect for right wall of the heart to be involved. And another additional clue what you can look at is, let me show you from this diagram. So this is lead 3 and lead 2. So if the magnitude of ST segment elevation is greater in lead 3, so this is the right part of the heart, so the ST segment elevation, if it is greater, then the pathology will be in right side. It means the right coronary artery will be involved. So if the ST segment elevation in lead 3 is greater than lead 2, then we have suspicion for right wall of the heart to be involved. And another thing what we can look for is like reciprocal changes you might find in different leads, okay, and yes, and most importantly, as we have already told, where did the diagram go? So you see here, so this is lead 1. In lead 1, if there is any pathology in this side, it will be positive deflection in lead 1, but in right side there is the right heart, so pathology is here, so it will have negative deflection in lead 1. What I mean to say is that, so lead 1 is basically in this direction, lead 1 is basically in this direction. Suppose if the pathology in left side, as we have already discussed, lead 1 is for left side, isn't it? Lead 1 is for left side. So if in lead 1, so lead 1 is for left side. However, if pathology will be in right side, then the deflection in lead 1 will be negative, isn't it? Because of reciprocal relationship. So when there is right side pathology, then lead 1 will have negative deflection. So lead 1 will have negative ST elevation, that means ST segment will be depressed. So ST segment depressed, okay. And another thing to keep in mind is that actually to find right ventricular involvement, there is a lead called V4R or V5R, V3R, Among them, the most specific being the V4R. So in case of V4R, you will be having ST segment elevation and upright T wave, which are more prominent than V1 and V2. And if there is changes in V4R, then right side of the heart is involved. So that idea you can have. So V4R could be also the MCQ question, like which is the most specific tool used. So in this here you place the V4 lead. So if you keep that V4 lead in this part of the heart, that is right side of the heart, same position, that is mid clavicular line, then it becomes the V4R, and you have find ST segment elevation and upright T wave. So is it clear? I hope so it is clear.